Dr. Natasha Tipnis is a consultant in neurology and epilepsy at Jaslok Hospital and Research Center. She's also a postdoctoral fellowship in epilepsy from KEM Hospital and State GS Medical College. She has also undergone training in epilepsy at Queen Elizabeth University Hospital, Glasgow, UK. Her talk today will be on examination of cranial nerves and their clinical significance. As is true with all other problems, patients with cranial nerve disorders will first report to the general practitioner. Madam.
Do we start? Do we wait for a minute?
Yeah, we can start. It will be a 30-minute talk.
Okay.
We can start. People are moving in.
Can't see a lot of people here also. Waiting
People
for
are moving in. Yeah, they're moving in. Once you start.
Okay. Fine. Hi. Hello, everybody. I'm first of all, I would like to say a big thank you for being invited to give this talk. Thank you to the association and thank you to all the members on the board for being kind enough to invite me. I've given a few online talks for the association and I always begin by thanking all the general practitioners. So that is how I'm going to begin today as well. Thank you so much. And it is only when you are a student in a medical college, you do not so much understand or get to feel the value of a general practitioner because you feel okay, it's just somebody just does a basic qualification, goes out, starts practice. But when you actually come in and start practice as a specialist, as a super specialist, and it's then that you realize the value of these silent crusaders, as I like to call them, who are the bridge between all of these hi-fi things that science has managed to achieve and the humble patient who just wants somebody to sit and hold his or her hand and explain what the disease is all about to them. And that is why I would like to begin the talk by, honestly clapping for all of you silent crusaders, because day in and day out, you sit in your OPDs and explain the same thing again and again to the 100th, 150th patient. And what you do for health in general for the country is something that a specialist or a super specialist can never aim at achieving. So I'd just like to say a big, big thank you to all of you. Thank you so much. The talk today is on cranial nerves. The reason for choosing this topic was because the cranial nerves, are something which is not very clearly understood. It is something that a lot of us do not pay a lot of attention to at the initial periods of MBBS, for example. And it is also something that becomes a little confusing as we move on because there are too many of them, there are 12 of them, remembering their names is difficult, forget going ahead. And the disorders associated with them are complicated, and often we fall into a trap where we think that this is not something which I can do or this is not something that I can manage, and so let's just refer. But what happens is that the patients, as I said in the beginning of the talk, their ultimate decision making depends on what their GP tells them. So I'm just going to focus on some very, very basic important points here and ensure that when the patient needs a referral or when the patient needs a treatment for a cranial nerve disorder, all the general practitioners sitting here would be able to guide their patients in the right direction, and that is it. That's all this talk is all about. So on the slides you can see our cranial nerves, and of course they are mentioned. We usually tend to call them by their numbers more than by their names. Okay. So if you see cranial nerve number 2, the optic nerve is associated with vision, and the 3, 4 and 6, the oculomotor, trochlear and the abducens are the ones which are associated with vision as well. So because vision is such an important part of cranial nerve examination, we will go with vision first. Before we start with vision, just a small note about the olfactory nerve. We usually do not examine the olfactory nerve, but if a patient comes to you with an acute loss of smell, nothing else, that means there might be something wrong in the olfactory lobe and the surrounding frontal lobe area. So you may In a patient who comes to you with sudden loss of smell and nothing else, you may wish to consider an MRI to rule out some lesion in the frontal lobe. So that is just about the olfactory nerve. And one more thing, patients who later on develop Parkinsonism in life sometimes have some sort of olfactory symptoms to begin with. So that's about the olfactory nerve. Now this is about what do you do, how do you do a neuro-ophthal examination in your office or in your OPD. You first take the history and as is with everything else, acute, subacute, chronic is very important. You then check the visual acuity. So it would be it's really helpful to have a visual acuity chart in your office, and it's nice to when you know where the patient is sitting, it's nice to keep the chart at an appropriate distance of 6 meters from where the patient is sitting, and it should be kept as it is, so you don't have to move around, the patient doesn't have to move around, you can check visual acuity. It's simple, you just close one eye, ask them to read, close another, ask them to read. Okay, function of the pupil, again, very, very simple, but can you use a mobile torch? Yes, you can use a mobile torch. You can use any torch. A yellow torch is preferable because of the color of the Indian eyes. We usually have darker eyes, which is why we say you can use yellow torches, and yellow torches are preferable. But the most important thing is that the rest of the room has to be dark. So you have to find a way to make the ambient room dark and then check the pupils, of course. Ocular movements, so we will have slides on how we check ocular movements. Pursuits, saccades and pursuits are important. I will tell you why. If a patient comes to you and the patient has Parkinson's and you are treating the patient for Parkinson's for many years now, patient is responding, maybe not responding, it's always a good idea to check for two things. It's a good idea to check for pursuits. Pursuits is basically look at my finger, look here, follow my finger where it goes, follow my finger where it goes, follow my finger where it goes. That's it, that's pursuits, okay? Saccades is look up, look down, look up, look down, look up, look down, look here, look here, look here, look here. That's saccades. So if you have a patient who has Parkinson's, who is following up with you, taking medications for Parkinson's, it's always a good idea to do this when the patient comes to you for the first time and then on follow-up. Because if the patient has got Parkinson's plus, as we call it, PSP, okay, it's possible that these eye movements will get affected very early on, and that will give you a sort of a hint that maybe this patient needs to be referred further, or maybe this patient is something else than Parkinson's. And sometimes that hint is enough. Another place where you need to check these saccades is, although diseases like spinocerebellar ataxia seem like something that is in textbooks only, the problem with India is that just like the West has Ashkenazi Jews, we have Agarwals. And certain forms of spinocerebellar ataxia are extremely common in the Agarwal community. So if you're checking for saccades, if you're checking for pursuits, you find that eye movements are not quite what they are, it might just help you, ask the patient about the community, about the heritage, about genetics, and then maybe, take the conversation forward from there. So that's about saccades and pursuits. And then of course you should do a visual field testing. A visual field testing is just basic perimetry, okay? So I'm just going to move here, okay? So say I am the doctor, you are the patient, you just sit in front of me, okay? The patient sits in front of me. Your nose and the patient's nose should be at the same level. All you have to do is you have to ask the patient to look at you in the eye, okay? And take your finger and say, tell me when you see the finger. And you and the patient should be able to see the finger at the same time. So you do this in all directions, this way, this way, this way, and this way. And that's common perimetry. What perimetry does is it shows you the field of vision, and field of vision is usually associated with higher up disorders in the cortex. So sometimes a patient may have had a stroke, before, and there may not be other very apparent signs. But if you have a visual field defect, it will be very clear. Another place where visual field testing is extremely important is if the patient has what we call pituitary tumors, okay? So anything in the pituitary, there may be a visual field deficit. So that's why this is very simple, right? It hardly takes any time and you get to do it easily in an OPD, but it gives you a hint that this person may need an MRI. And visual, again, very important, patient will never say that they have a visual field defect, because they will always adjust their head and they will make sure that they see everything. Okay, so that's it. Fundoscopy, honestly, I know that senior neurologists might disagree with me, but it is now so easy to refer a patient to an ophthalmologist for a fundus photograph. And when you can get the photograph for an objective viewing, it's okay to not perform a fundoscopy in the OPD. But remember that if you are suspecting a raised intracranial tension, if you are suspecting that this patient may have either a raised ICT or for some reason has headache, has vomiting or has blurring of vision, and if you feel that even the vision is normal but the patient is still having all of these complaints, of course first you will check the vision, but if you feel that the vision is normal and the patient still has all these complaints, refer the patient. It is very easy to get a fundus photograph these days, so you can always refer the patient for a fundus examination. And that's it. Optokinetic nystagmus again is the same as checking for saccades. It's if you wish to check it in your OPD, you need what we call an OKN tape. It's really simple. It's actually a tape where you have the white and the red, and then the white and the red, and you have to ask the patient to count the reds. Same thing as pursuits and saccades. It helps you with complicated Parkinson's. It helps you diagnose certain spinocerebellar disorders. Okay, so coming back to eye examination, what is important, whether it is acute, subacute or chronic, whether it is monoocular versus binocular, pain or not, squint or not, redness or not, any other associated symptoms, and very important, history of medicinal use. There are a lot of medications which affect the retina, there are a lot of medications which affect the optic nerves. Most common and the case that we always make a point about is, all of you know ethambutol, which is used in AKT. Okay, so this is basically what I was trying to talk about. On the far left is the Ishihara chart. Ishihara chart is also very nicely available. Why I am harping about the Ishihara chart today is because it tests color vision, and in cases of optic neuritis, which is one of the main things on my mind today, to get you guys absolutely clear, spot on optic neuritis. Color vision goes really quick in optic neuritis. So a patient of optic neuritis may be able to read, but color vision will definitely be affected 100%. Okay, this is the confrontation testing where we were checking the perimetry, which I was talking about. That is the picture. And of course, this is your usual Snell's chart. Okay, so as I said, optic neuritis, top of my list today, that every GP should know about optic neuritis. So that, on that side, is what you see in the pupil when you're checking for RAPD. Okay, that's the swinging flashlight test. And these are the gradings of the RAPD. So you can, maybe take a photo for future reference about the gradings. But basically what you do in an RAPD is you make the room totally dark, okay? And this is very important because you can pick up optic nerve disorders very quick by using this RAPD thing. So you make the room really, really dark, and you ask the patient to, you stand in front of the patient, you ask the patient to cover one eye, or you can cover one eye of the patient. It's better to cover one eye of the patient yourself. You take the flashlight, you shine it for a good 15 seconds in one eye, okay? And then you remove this and then you shine it in the other eye. Now, what is expected to happen in any normal person when you shine a flashlight into their eyes? It's supposed to, the pupils will constrict, right? That's normal. Now, what happens in RAPD? You have to know that the pupillary constriction or the pupillary constriction reflex is bilateral. So when light is shown in one eye, the other pupil constricts as well. So the afferent pathway or the sensory pathway, for, say for example of your left eye, is working perfectly well. So when I shine the light in the left eye, the left pupil constricts and so does the right. But then the afferent pathway or the sensory pathway of the right eye is not functioning as well. So when I'm moving the flashlight to the right eye, the input that the brain should get for constricting the pupil is not there. So neither the right nor the left eye will constrict. But what happens? That right eye was already constricted, right? Because you were shining here for a good 15 seconds. So to your eye, it will appear as if that right eye, which was supposed to constrict, is actually dilating. And that's why you can see there are grades. So pupil enlarges as soon as the light is swung, pupil enlarges, but after a short delay, and a subtle when, okay, forget the subtle. But so if you can see that the pupil is enlarging suddenly as soon as you move the flashlight, then it's a very strong RAPD. If it takes some time for it to enlarge, probably a lesser degree. And if this is present, it is a telltale sign of the fact that the optic nerve is involved and you have to do something about it quick. Okay? So just remember this mnemonic: transient visual loss, down in days, up in months, young adults, painful. Optic neuritis is painful. If it is painless, it is most likely an arthritic thing. Of course, giant cell arthritis is also arthritic, but I'm talking about the ischemic, not the non-ischemic. The ischemic things where the artery has gone and suddenly there is painless loss. We all know about it. That's a stroke. It needs treatment like a stroke, but painful. And your ophthalmological findings, sometimes you know, when you get a fundus done in case of an optic neuritis, which is acute, you may find papillitis, you may not find papillitis. There is definitely not going to be papilledema in the initial stages. So ophthalmological findings, your ophthalmoscope findings are not quite there. Central scotoma, central visual loss, rapid afferent pupillary defect, and this last line is basically this is an hereditary condition that may look like optic neuritis, so you have to make sure that it doesn't run in the family. And I want to add another C to it, which is color vision gone. So if all of these things are there, if you see optic neuritis, and if one thing you want to take away from this lecture, if all of these things are present, if the patient is young and the patient is coming you with a painful visual loss in one eye, it is going down fast, it is not improving, refer to an ophthalmologist and a neurologist immediately. When the neurologist or the ophthalmologist say that get a VP done, the patient calls you from their office, sir, ये हमें VP करने को बोल रहे हैं, अभी करो, अभी करो, okay? सर ये बोल रहे हैं 2 टाइप का VP होता है, फ्लैश VP और चेकर्ड बोर्ड VP. कौन सा VP करें? चेकर बोर्ड करो, चेकर्ड बोर्ड बेटर होता है. सर ये बोल रहे हैं कि अभी के अभी MRI करना है, आंख में प्रॉब्लम है, स्पाइन का करने को बोल रहे हैं, अभी करो, अभी, अगर अभी हो सकता है तो अभी करो. एंड मोस्ट इंपॉर्टेंट, सर बोल रहे हैं स्टीरॉइड की दवाई लेनी पड़ेगी, वो भी इंजेक्शन. आंख बचानी है ना, पहले स्टीरॉइड लो, बाकी बाद में सब करो. सो दिस वन थिंग, बिकॉज देयर इज सो मच ऑफ रिलक्टेंस ऑन द पॉइंट ऑफ द पेशेंट. सी, giving injectable methyl prednisolone to a patient who does not have optic neuritis, I know methyl prednisolone injectable has side effects, but giving injectable methyl prednisolone, let me say, to a non-diabetic patient less than 60 years of age with no comorbidities, who does not have optic neuritis, will do nothing to the patient. Not giving it to somebody with optic neuritis, the patient will lose their vision. So I know that, you know, the steroid has side effects. I agree to everything. But आप ये देख लो कि पलड़ा कहाँ भारी है. You are talking about loss of vision in a young, able-bodied person versus maybe some side effects. So just if they call you and say that I have been diagnosed with optic neuritis, they are telling me to take a steroid now, you take a steroid now. That should be the approach. And if there's one thing that I want you to take away from this lecture, it is this, because as a neurologist, when I see optic neuritis, hundreds of times this thing has come up, and it's always like, let me call my GP and confirm. So like, हाथ जोड़ के नम्र विनंती, methyl prednisolone को हाँ बोलो. Okay, ptosis is paralysis of, basically what causes ptosis, either it is oculomotor nerve paralysis, could be Horner's, could be myasthenia. Mostly you people will be seeing myasthenia related ptosis a lot. Ocular myasthenia is a reality, so it is possible that the patient will come to you for the evening OPD at 7 o'clock, show you the eye and say कि ये बस ये आँख है डॉक्टर साहब, और कुछ नहीं है, पेन वेन कुछ नहीं है, चबाने में कोई दिक्कत नहीं है, नाक से कोई पानी नहीं निकलता है, वीकनेस नहीं होता है, कुछ नहीं होता है. And elderlies will come to you with this, so it will be even more confusing, because you might be thinking, is this senile ptosis, you know? But always get investigated. Myasthenia is an easily treatable condition. Lots of treatment options. Of course, we'll need another lecture to talk about treatment options of myasthenia. But most important, easily diagnosable. One blood test, one repetitive nerve stimulation. Serum AChR antibody levels, repetitive nerve stimulation, 2 blood test कर लिए, you have your diagnosis, patient का ptosis ठीक हो सकता है. Horner's syndrome is serious. In Horner's syndrome, along with ptosis, you have miosis, the eye becomes small, you have anhidrosis, and you have loss of ciliospinal reflex. Why is Horner's syndrome important? Amongst other things, stroke वगैरह, Horner's syndrome also happens when you have a tumor, a Pancoast tumor or any tumor in the upper segment of the lung. So sometimes the first thought, you know, कि इसको कुछ हो सकता है, could come from a Horner's. So if you pick up a Horner's and if you ask the patient to get investigated, always works in your favor. Okay, this is how you check for eye movements. So you basically Okay, sorry, I'm going to be doing a lot of this. So you basically stand in front of the patient like this, and you go this. No, I am not speaking. Just look here, look there, look up, look down. Oh, I can use this mic, it's fine. So you basically just stand in front of the patient and you go look up, look down. So when up and down, you have to keep your finger like this, and then you have to go look this side and look this side. Don't move your head. And look this side, look this side, look this side, you look this side. You can take a photo of this picture. It is basically what muscle you're checking, and up on in gray, it is what nerve is associated with the muscle that you're checking. Oh, sorry. I'll give you time to take the picture. So of course, 3, 4, 6, everyone knows sixth nerve. Sixth nerve paralysis in an acute condition associated with headache and vomiting means increased intracranial tension. Any patient with really bad increased intracranial tension will come to you with headache, vomiting, and an isolated sixth nerve paralysis. Very common. This is less common, but patients will come to you with this. This is cavernous sinus thrombosis. You could see this in patients with diabetes. You could see this in patients with any sort of, and now you know this whole immune compromised status has become a problem because there's so many people on immune suppressant therapies. Okay, so cavernous sinus, it's mentioned over there. So a patient with cavernous sinus syndrome will come to you with 3, 4, 6 nerve involvement. History will be headache, edema, cranial nerve paralysis, double vision. Could have seizures. So get an MRI urgently because the patient may need broad spectrum antibiotics and other treatment, and sometimes if it's a fungal infection causing cavernous sinus thrombosis, we are really in deep trouble. So important to identify. Tolosa-Hunt syndrome, a benign condition that resembles findings that could be associated with cavernous sinus like, but of course it is a benign syndrome, but again it is associated with painful ophthalmoplegia and cranial nerve palsy. Usually Tolosa-Hunt just requires steroids and nothing else. You may notice that a lot of neurological conditions do require steroids as treatment, and we are really not the villains because they do work. So Tolosa-Hunt, steroids do work. Cavernous sinus, on the other hand, steroids will cause problems. So just a small, so just a small thing that if somebody comes to you with cranial nerve 3, 4, 6 involvement, that is diplopia, painful ophthalmoplegia, that is inability to move the eye in either direction, and pain when you try to move the eye in either direction. So if a patient comes to you with diplopia, ophthalmoplegia, what you can do in your clinic is you can do this testing. This testing will tell you what nerves are involved, so you can note down what nerves are involved, and then this patient will require standard MRI, a standard MRI brain with contrast. Why contrast? Because these are usually inflammatory conditions or infectious conditions which are better picked up on contrast. So patient comes to you, painful ophthalmoplegia, MRI brain with contrast. Mostly the radiologist will give you the diagnosis and then you can refer accordingly. Okay, if the patient has cavernous sinus thrombosis, the patient may have fever, the patient may have signs of what we call a toxic patient. In that case, admit first and then MRI. If there are no toxic into inverted commas sign, you can always send these patients for a scan first and then decide later. Okay, so this is the end of the optic nerves. Coming to a nerve which you know as well as me and you diagnose more than me, trigeminal. So many trigeminal neuralgias all over the place, and a very common disorder, obviously very easily treatable disorder, and one of those disorders which patients are really happy coming to the GP to. Okay, so this is the course of the trigeminal nerve. These are the divisions of the trigeminal nerve. So if you were to send probably your trigeminal neuralgia patient to a neurologist, we write weird things like V1 territory neuralgia, V2 territory neuralgia and stuff like that. Important thing to remember for trigeminal neuralgia is, first thing, sometimes patients with pre-existing trigeminal neuralgia tend to develop herpes here, okay, in the V1 region. And the pain of herpes is similar to the pain of trigeminal neuralgia because neuralgia, right? So if a patient with trigeminal neuralgia has developed herpes zoster, then there will be new skin lesions and you have to be on the lookout for them, okay? But what I want to tell you about the fifth nerve or the trigeminal neuralgia today is something very different. It is this. It is that you please ask for an MRI with cis imaging of the trigeminal nerve. Nerve block is an option. Microvascular microvascular decompression is an option. What you're seeing here is how the superior cerebellar artery, which exists the pons around the same place as the trigeminal nerve, impinges upon this nerve. And the radiologists have given us with this beautiful sequence, a CIS and image and an angiogram. And this is done at all places in Mumbai. It is very easily available. It's CISS imaging and an angiogram. If your patient has trigeminal neuralgia that can be controlled with just carbamazepine, fantastic. No need to go and do all of this. If your patient has trigeminal neuralgia that's needing carbamazepine and little bit of gabapentin, pregabalin, still okay. But you've got a patient who comes back to you with recalcitrant trigeminal neuralgia, not responding to medications, get the scan done. Send them to a neurosurgeon, at least they have an option. See, we are not saying that this has to be done, but there is an option. I'm also not saying that microvascular decompression solves all their problems forever. Microvascular decompression may work for 10 years, some patients, 7 years, some patients. But see, if you have a disorder which is causing a problem when you eat, when you brush, then 10 years is a huge time, right? So trigeminal neuralgia, you all know how to diagnose and treat, but this is one thing that I wanted to point out. CP angle tumor. Have you seen this MRI? I'm sure a lot of you must have seen these MRIs, these little things that look like ice cream cones, vestibular schwannomas. They involve the 7th nerve, they involve the 8th nerve, they basically come out of the CP angle. CP angle tumors, usually we associate them with 7th and 8th nerve involvement, and because they are vestibular schwannomas, we want the 8th nerve to be involved first. But this is very classical neurology teaching that it is usually the V1 segment of the trigeminal which gets affected first. So some patient comes to you with
last 4 minutes.
Yeah, some patient comes to you with numbness here. Maybe you might want to get a scan done. There might be something sitting in their brain. Facial nerve, everyone knows how to test facial nerve, so I'm not going to harp upon it much. This is just the important things I want to say about facial nerve. Differentiating between UMN and LMN is most important. And how do you differentiate between UMN and LMN? You ask the patient to look up. You look for the frowns on the forehead. Frown on the forehead present, UMN, frown on the forehead absent, LMN. Bilateral lower motor neuron facial paralysis, and we have learned this the hard way in COVID, is very associated with GBS. So patient is ekdam hale, hearty, no problem, comes to you with bilateral lower motor neuron facial. First thing on your mind should be, I want to rule out GBS for this patient. Again, GBS, why? Acute condition, very life-threatening and easily treatable. Okay, of course, sarcoidosis is something that should be kept in mind, but in India, bilateral acute onset lower motor neuron facial paralysis, first thing that should strike your mind is, let me evaluate this patient for GBS. Okay, and if it's upper motor neuron, it is usually a stroke, and there have been so many GP lectures about stroke, so I don't need to tell you anything about treatment of a stroke, but acute onset upper motor neuron facial involvement is a stroke. It has to be treated as a stroke. These are cranial nerves 9, 10, 11, 12. What do you need to check for that? You need to check for swallowing, position of the uvula. Ask the patient to say, ah, and look for where the uvula is. Is it central or not? Check the gag reflex, very easily check difficult, I don't know why people don't do it. It's an easily elicitable reflex. Look for voice and cough. Hoarseness of voice, inability to cough points towards the vagus involvement, the recurrent laryngeal nerve. This is not said enough, but thyroid surgeries are often associated with involvement of the recurrent laryngeal nerve. So that your sternocleidomastoid muscle is also supplied by a cranial nerve. It is the spinal accessory. And of course, there is the tongue, which is supplied by the hypoglossal, so lower cranial nerves. This is a very nice slide. You can again take a photograph of cranial nerves and swallow. So we also have lack of time. You can just take a picture and you can read about it at home. It's really nice about which nerve is involved in what stage of swallowing and what happens if it's damaged. Okay, last but not the least, I want to say something about the 9, 10, 11, 12 cranial nerves. I was taught about by all my teachers that uncommon presentations of common illnesses happen more commonly than common presentations of uncommon illnesses. So you have to remember that if you have 9, 10, 11, 12 involvement in India, you have to think of TB, 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 pehla 3 TB, uske baad kuch aur socho, okay? There are a lot of inflammatory conditions that have come up because we progress, science progresses, so there are many new things that have come up, but a patient comes comes to you with an acute involvement of, we call them the lower cranial nerves, okay? Easy to remember, lower cranial nerves. Two things, stroke, so of course get an MRI done, but when you get an MRI done, always get it with contrast. If it is a stroke, of course it's a stroke. It could be a lateral medullary syndrome or a medial medullary syndrome or any one of these medullary involvements or pontine involvement, okay? But if it's not a stroke, it is most likely TB, so treat for TB. So in summary, this is all I want to say, that history taking gives important clues. It's always important to remember that something acute and life-threatening should be expedited and treated fast. A quick examination can definitely be performed in the OPD. It is nothing that cannot be performed at the level of a GP. And I hope that, today's lecture has given you a little bit of knowledge and confidence to be able to examine cranial nerves by yourself. And I think the role of the GP is to refer to the right person at the right time. So I hope this lecture helps you to refer the patient to the right person at the right time. Once again, thank you very much. Thank you.
Thanks, Dr. Natasha. I welcome Dr. Bharat Bhatt, our past president, to felicitate Dr. Natasha.